afternoon, everyone. My name is Pete Spadaro. I am the President and Chief Commercial Officer of Syncardia. Thank you so much for joining us today for our discussion on, our case-based discussion on cardiomyopathies. And just wanted to say a quick hello and let you know that Syncardia is continuing to work on many different projects. We're made great strides in the last year from both technical product developments, data development. Unfortunately, some of the cancellations have precluded us from sharing that, but we hope to be sharing some really compelling data with you very soon. We are experiencing a lot of interest from new centers, both in the US and around the world. And a special welcome to our surgeons and cardiologists from India who are getting very close to starting their TH programs in that country. So obviously the global pandemic has slowed us to some degree, but we have decided to embrace these new modes of awareness and education. And this will be the first in a series that we hope to put together in the weeks and months ahead. So thank you for joining. A lot more to come from Syncardia in numerous ways. And with that, I would like to introduce our moderator. And first of all, I'd like to thank Dr. Shah, Dr. Parikh, and Dr. Arabia for taking their time today. But Dr. Shah will be moderating today, and Keyur, I'll throw it over to you.
Thank you, Peter. And I certainly, on behalf of my co-presenters, Dr. Parikh and Dr. Arabia, I'd like to thank Syncardia for putting this together. Today, we're going to discuss the role of total heart replacement for thick heart cardiomyopathies. I'm going to start by providing a little bit of background, and then I'll hand over the presentation to my co-presenters. And hopefully we'll have enough time for any questions or discussion at the end. I'm going to encourage everyone on the virtual conference call to submit any questions to the chat room, and please mute your microphones if you're not speaking. So today we're really going to discuss the potential utility for total heart replacement for patients with advancing heart failure and either thick heart or restrictive physiology cardiomyopathies. They may include, but are not limited to, some of the images I'm showing you here: MRIs of patients with cardiac amyloidosis, apical hypertrophic cardiomyopathy, asymmetric LV septal wall hypertrophic cardiomyopathy, or Fabry's disease, which I don't have images for, idiopathic restrictive cardiomyopathies, which we've all had challenging times treating. These diseases, some of them systemic illnesses, some of them isolated cardiomyopathies, have unique challenges that sometimes make it difficult to implant an LVAD. Many of them are associated with very small LV cavities. They often involve both ventricles and have either restrictive heart failure or RV failure. They often and frequently are associated with arrhythmias, many of them malignant. Also, this population is very challenging because diagnosis is often late, and once patients start declining, it's a rather rapid descent. We've tried as a field and a community to try to treat patients with VADs who have restrictive physiology or smaller LV cavities. These are data from the Mayo Clinic accumulated over several years, where they published and shared their experience of implanting continuous flow LVADs in patients with restrictive heart disease, many of them hypertrophic or amyloid patients. As you can see here, the survival was 0% in patients who received a LVAD and had an LV end diastolic diameter of less than 4.6 centimeters. With introduction of continuous flow devices, survival on the heart transplant list has improved for patients who have non-ischemic or ischemic dilated cardiomyopathies. The data from waitlist and UNOS data was published by the Utah group here only in the last year or two. And what they found is patients with thick hearts or hypertrophic cardiomyopathies still had poorer survivals and exhibited no improvement in recent years like the other types of heart disease. So this remains a population that is difficult to treat with traditional MCS devices, that presents clinically very ill and can rapidly decline with very few tools at our hands. So with that being said, I'm going to hand the presentation over to Dr. Parikh from Mount Sinai Hospital to discuss his case.
Thank you, Dr. Shah. Thank you, Dr. Shah, for that introduction, and Syncardia for inviting us to share our experience and the case with the community. So let me just expand this here. So today I wanted to present to you a patient of ours who is a 47-year-old gentleman with a history of idiopathic restricted cardiomyopathy, who presented in acute decompensated heart failure with progressive class 4 symptoms. He had ascites and anasarca essentially one day after he returned back from his trip from Bangladesh. He had a past medical history that comprised of non-ischemic cardiomyopathy that was diagnosed in 2011, poorly controlled diabetes with a hemoglobin A1C of 10.2, atrial fibrillation, as well as chronic kidney disease. His last follow-up in the United States with a cardiologist was in December of 2018. At the time, he displayed NYHA class 3 symptoms, and as evaluation for his cardiomyopathy, had right heart catheterization done that showed elevated filling pressures and a low cardiac output. As you can see here, his RA was 25, PA was 38/25 with a mean of 29, and a pulmonary capillary wedge pressure of 22 with V waves to 35. There is somewhat of an equalization of the diastolic pressure gradients there, suggesting a restricted phenomenon. And he had a cardiac MRI performed to better understand the etiology of that. 35% of the normal left ventricular size was not dilated, and there was no evidence of fibrosis or infiltrated cardiomyopathy on that MRI. In the interim, since his last presentation, he had multiple admissions or hospitalizations in Bangladesh for decompensated heart failure until he decided to move back to the US and seek medical care. And he essentially came from the airport to our hospital. When we met him, he appeared quite frail, very malnourished, cachectic. He was only 5'1" in height and weighed about 130 pounds, but grossly anosarchic. He has decreased breath sounds. He was tachycardic. And his abdomen was distended with ascites that was present on exam. As I mentioned, he was lukewarm. He had tubeless edema and anasarca with edema all the way up to his mid-back. And laboratory evaluation also suggested how chronically debilitated he had become. He was hyponatremic to 125. He had evidence of end organ dysfunction with a creatinine of 1.86. He was severely hypoalbuminic with albumin of 1.8 and a pre-albumin of only 17.7. Here you see his chest X-ray with bilateral pleural effusions as well. So he was initiated on milrinone, and here is his echocardiogram. His parasternal long axis view, his LV dimensions, at least end diastolic dimension, was only about 4.7 centimeters, so not dilated as one would expect in end stage of a non-ischemic dilated cardiomyopathy. And on the right is your apical four-chamber view, shows severely depressed EF, but again, remarkably not really dilated left ventricle. And his RV, although squeezing, it's moderately dysfunctional as well with biatrial enlargement. The official read of the echocardiogram showed an EF of around 20%. His LV diastolic dimension was around 4.7 centimeters. Mild to moderate RV dysfunction by echocardiogram, biatrial enlargement. He also had mild to moderate MR as well as moderate to severe TR, which is not displayed here on the screen. We proceeded to perform a right heart catheterization, and on milrinone of 0.375, again, he has severely elevated filling pressures that you can see here, RA of 25, PA of 44/25 with a mean of 31 and a wedge of 25. Again, sort of like your diastolic equalization with a low cardiac index of 1.6. Hemodynamically, the RV was again struggling. He had a CVP to wedge pressure of 1 and a PAPI of only 0.76. At that time, we proceeded to escalate inotropic support for him, and in hopes to sort of support him better, we placed an intra-aortic balloon pump. Given his left ventricular and diastolic dimension and cavity size, an Impella or other temporary mechanical support devices, we contemplated about, but felt that we may struggle with that with shutdown or ventricular arrhythmias. He was already having ectopy, so we proceeded with intra-aortic balloon pump. With escalation of diuresis with furosemide infusion, aquaphoresis of CHF solution, which is essentially just ultrafiltration, and eventually requiring CVH for progressive renal dysfunction. Despite all these measures, he remained in persistent shock with elevated filling pressures, and we just could not unload him. Just sort of demonstrating our struggle with dealing with restrictive physiology. Despite 3 inotropes, a vasopressor, and a balloon pump, he essentially had hemodynamics that were unchanged. We could not get to decongest him. And at that point, we were contemplating options for providing this gentleman, a young 47-year-old guy, with biventricular support. I'm sorry? So cardiac transplantation obviously would be an optimal choice of therapy for cardiac replacement in this young gentleman. However, we felt at the time that he was too chronically malnourished and debilitated with end organ dysfunction to tolerate transplantation. And should he improve from this, then he should certainly be considered one. The alternate modalities of biventricular support we contemplated were placing biventricular centromags or Syncardia TAH. One concern, as we sort of initially mentioned, was his size. He was 5'1", around 130 pounds or so. Here, the CT chest that demonstrated at the AP, the T10 level, the AP diameter was around 11 centimeters. So felt that a Syncardia TAH device, a 70cc device, would be a fit for this gentleman. At the time, the 50cc one was still not approved for a bridge for an indication for an adult yet, and so we proceeded with placement of the Syncardia 70cc TAH on February 4th of this year as an Intermax 1 in order to support him, provide him with biventricular support, and give him time to reverse his profound cardiac cachexia that he had developed. As one can imagine, the initial portion of the TAH procedure was relatively routine. We were very fortunate to work with Dr. Ani Anwu, who's a phenomenal surgeon who's done many of the TAH device implants before. However, towards the end of the case, during chest closure, we did run into some difficulty due to the small size of the chest cavity. When he attempted to close the chest, there was compression of the pulmonary veins leading to issues with flows. But his ingenuity and his creativeness, he used sutures to essentially suture the cannula and the ventricle to the chest cavity, relieving the pressures that he was placing on the IVC and the pulmonary vasculature. And he was able to, after trial and error, to close the chest with good outcome and good flows. I believe Dr. Ani Anwu has joined us on the call as well, so would love his insight at the end of discussion as well to see his thought process during the surgery and how creative it was with the surgery. Post-TAH placement, he, as one can imagine, he's run into a few bumps. He developed respiratory failure and has required tracheostomy. He's in renal failure. He's currently requiring renal replacement therapy and has bouts of sepsis with a candidemia that has since cleared with antifungals and recurrent episodes of Klebsiella pneumonia bacteremia, which he's treated for antibiotics. We're focusing on essentially supporting him through this and address his nutritional status, getting him physically ready for an eventual transplantation, reverse this profound cachexia that he had developed over a period of several months, if not years. And he's currently listed at our institution for a combined heart-kidney transplant.
Aditya, thank you very much for that presentation. We don't have any questions in the chat room, and what we could possibly do is spend a few minutes discussing this case if anybody has any comments from the audience. But I would certainly like to highlight this. This was probably one of the highest risk patients we would have considered for a TAH. Extraordinary characteristics of progressive disease, anatomically a small patient who's already cachectic, compromised end organ function, and clearly an intermax 0.5 shock. And congratulations on at least getting him this far. Hopefully you're able to resuscitate him to make him appropriately nutritionally to get him to transplantation. Maybe we could have the surgeon comment on some of the challenges of fit here during the surgery.
Yeah, Francisco Rabia, let me add a few comments. Those were two great presentations. The physiology is very similar in the patient with amyloid, which we have done several patients with amyloid. And those have been that have non-extra cardiac disease. All the amyloid is in the heart, biopsy proven. And the physiology is very, very similar. And we did in Los Angeles, we did 5 of them, and they all survived post-transplant. And actually, we described this in a small series recently, the experience of doing MCS in patients with amyloid. So a few things from the surgical technique. I had some slides. I'm not too sure where they are there, but I don't know if they're in Dr. Shah's at the end of his presentation, or that's where I had put them in.
You're muted.
Adi, could you stop sharing so we could pull up Dr. Arabia's slides?
Yes, absolutely. There we go.
I just want to bring some points. The technique, at least in the amyloid patient, is very similar to the patient with hypertrophy. The only difference is that in the amyloid patient, the muscles, once you cut it, the left ventricular muscle, it looks like red velvet cake, and it has a similar consistency. But the important things are, if I can show you the slides. Okay, this is using the same pictures that Dr. Shah used to give you an idea. So you go and do the ventriculectomy at the same level as the conventional resection. Always staying close to the AV groove, and you can see the line of resection here, right below the AV groove. And if you go to the next slide, it's just a schematic. I don't know if I have control. So it is important that the muscles here are very, very thick. So if you leave too much muscle, then you're gonna have all these bulging muscle around the atrial quick. So you need to stay close to the AV groove. And if it's still very thick, you can actually shave some of the muscle under the mitral and tricuspid valves. So the suture line is nice and clean. So those are important things for on the surgical aspect, then everything else is the same. Now, you can see those other 2 red lines that I put. Those are the shaving of the ventricular muscle that you have to do in order to reduce the thickness, both for hypertrophy or for amyloid, if it's too thick. The issue of closing the chest and having decreased cardiac output for compression. I used to do the same similar technique of trying to tag the TAH to the left. And what I have found over the years is, if for some reason you decide to leave the chest open in these patients, initially post-op because of bleeding or being a second, third time sternotomy, or they've been very ill before on ECMO or anticoagulate, and you decide to leave them open. Usually what I have found is when you come back 3-4 days later, is that you can close the chest with no problem. And you don't have to rotate or bring the device, tack it to the chest wall. And I'm not too sure if this is because some of the edema has resolved, but it's quite impressive that the majority of the patients, you can then close a few days later without having to tack the heart out of the way. So those are just some of the caveats on these patients with hypertrophic ventricles, either from IHSS or amyloid. You know, it's interesting because that series that was presented from the Mayo Clinic, I was there when one of those patients received an LVAD. And the next day we did an amyloid patient, we did a TAH. The patient who had the LVAD continued to have severe arrhythmias in the immediate postoperative period for the next 24, 48 hours, and was never able to get extubated and never left the ICU. While the TAH patient that had no further arrhythmia and no further hemodynamic issues was able to leave the ICU about a week later and transplanted several months later. So those anatomical differences are crucial. And that is one of the positions that the total artificial heart can be extremely beneficial, especially the patient who has hypertrophy and a small left and right ventricle. I'll be glad to answer questions along with the other speakers. And thank you for the opportunity.
Can for the audience and many of them who are new to device management and caring for patients after PAH, you guys describe some the clinical presentation for early or late venous compression. What should the clinician and surgeon look out for early postoperative and in the week after surgery?
Are you asking the speakers or the audience?
I'm asking whoever wants to answer.
Okay, so let me just say that the venous compression, you usually can identify within the first few minutes of bringing the sternum together. And it is something as simple as the pump output drops by 1 liter per minute. It's something, and although it's subtle, you have to be aware that that is a significant change, because if you don't address it there, believe me, in a few hours, the next 24 hours, it's going to be more pronounced. So you have to address it right there. The moment you bring the sternum, as you're looking at the blood pressure, and if it drops, you have venous compression.
Water.
We do have a question. One of the questions from the audience is, why not use a Centromag BiVAD in this scenario? I'll let Aditya comment on that.
No, certainly you're right. We did think about using Centromags as well as one of the other modalities that we thought about. But as you sort of pointed out earlier, Dr. Shah, that gentleman who has been essentially was Intramax 0.5 to 1. However, the chronicity of his symptoms sounded so prolonged, and he was so profoundly cachectic from his cardiac shock that he's been experiencing for all this time. We anticipate that the reversal of this process would be a prolonged one and a tour de force to bring this gentleman to resuscitate him. And it may not be limited to weeks to months, but perhaps slightly longer. And we had hoped that with the TH will provide us the opportunity to support him for a longer duration of time, perhaps even get him out of the hospital, allow him to resuscitate, reverse the cardiac cachexia that he's experienced over time, and be a better candidate for transplantation. And so that's why we chose to pursue a TAH. And we've had some success over the past year or so with TAHs as well. Last year we did, I believe, 7 TAHs as a bridge to, or 5 out of 7 who were bridged to transplant last year. So we had hoped that we can provide the same degree of support to him and make him a better candidate for transplant.
Yeah, that's a great question. And I can tell you that, you know, first, the TAH should not be used as a acute device. I have seen people trying to use the total artificial heart as an ECMO, trying to resuscitate. Those usually have an extremely poor outcome. Now, why use a TAH rather than a CentriMac? Well, the TAH offers you incredible more mobility. It allows the patient to be discharged home, which the CentriMac, you have the patient committed to the ICU, and you expose the patient whatever infectious agents might be in the intensive care unit. The total artificial heart is years ahead of a CentriMac. I know many hospitals have used that, but you can provide great support. You can get them ambulated, you can get them home. And that's a lot better than staying in an ICU for months and months, which I have seen patients on CentriMac.
Aditya, question from one of the audience. What is the current clinical state of the patient? And maybe this might be an opportunity to go through the expected and unexpected complications that you guys had after surgery.
No, exactly. And, you know, as one expected, even preoperatively, given his condition that he was in, that this will be a long tour de force to resuscitate this gentleman. And we've run into a few bumps along the ride. He early on developed respiratory failure and he was trached. He had renal failure even going into the operation. He's remained on renal replacement therapy. And as I pointed out in my slides, that unfortunately we're dealing with bouts of sepsis that we've run into and provided some bumps along the road. Unfortunately, he's currently just developed, over the past week, he's developed a recurrent episode of Klebsiella bacteremia, which has unfortunately had him take 2 steps back. But he's on the mend from that perspective, and he's getting treated with antibiotics. We're hoping that he could clear his cultures and we proceed. He is quite debilitated, but we're trying to sort of resuscitate him to the best of our abilities for now.
Did you mention that he had renal dysfunction going into the implant?
Yeah, he had chronic kidney disease at baseline, and he essentially became anuric in the process of decongesting him with this very restrictive physiology. And going into the operation, he was already on renal replacement therapy. Yeah,
you can see at least he had 2 major risk factors for morbidity. The renal dysfunction going into the implant with the renal dysfunction, and the other one is the cachexia. Malnourishment is one of the major risk factors too. So, you know, looking back at this patient, there is no surprise that he has had issues. But, you know, usually when the fact that you can provide an adequate cardiac output or pump output, sometimes it takes time, but it can reverse some of these things. I'm sure that's the hope for this patient.
We have a couple questions. We have a couple questions related to FIT and modeling for FIT using current technologies and imaging techniques. Would anyone like to comment on that when you're seeing that, especially a patient that's 5'1"?
Sure, I can make some comments. We have put total artificial heart at 70 cc's in 12-year-old kids who are not even 5 feet because the heart is big. And T10 was about 9 in that patient, 8.5 to 9. So I know we talk about T10 being 10, but there are other things that go into this. The size of the heart is important. If they have a large heart, even though it's a small person, you probably can put a total artificial heart by rotating it to the left side. In this patient who had a kind of a normal size heart, you can expect that you might have some some feeding problems or issues. You know, the company offers the virtual surgery with feeding of the heart, which we review several of those a month from all over the world, in making sure that either the 50 cc or the 70 cc is going to fit, and that is available. And it is extremely helpful for programs that are starting to get a pretty good idea. If the things that you can do when you're in the operating room that I have done over time, yes, I have tacked the heart to the left if I have to. I have opened the left pleural space to rotate the heart to the left. I have taken the inferior aspect of the sternum, the lower third, to be able to close, and all those patients have survived. So there are multiple things that you can do, but again, the one that I've been impressed the most is, if you have difficulty initially, is leave the patient open for a few days, diurese and get fluid off, and come back. And I have been amazed of how easier it is to close the chest.
So we have a question related to contraindications, or when anybody would say no, and I'll start with a few from our center. You know, I have to be honest with you, Adi, I thought this patient that you presented had remarkable number of risk factors, and we would have pontificated on whether to proceed or not, because one of the biggest challenges we've had is when we take the malnourished patient and put him through the surgery, because we kind of check every box for a complication afterwards. But when you have a young man like this and you're trying to give someone a shot, I completely understand. But if I just take a list of things, cachexia, frailty, malnutrition, if you put that into one category, if you're getting to someone who's chronically declined, it can be challenging. It can be a challenge. How about you guys? When do you guys become really concerned about implanting a TAH?
Yeah, I can say, you know, if they have multiple organ failure, that is not a good thing. If they're actively infected, if they have, like you mentioned, cachexia and malnourishment, and these are things that were published in the manuscript regarding the TAAs from data from the Intermax registry. All these risk factors are there. But I think one of the most important is not to use the total artificial heart to resuscitate patients. That is not a good idea. It is not an ECMO. It is not the equivalent of ECMO, and it should not be used instead of ECMO. If there is someone that you are extremely concerned if they have the ability for organ function to recover, then you probably should consider a short-term device, ECMO or Impellas, tandem heart, and see if you can revert some organ function prior to committing to an artificial heart. The artificial heart is almost a semi-elective surgery.
Very good point. And I'd add to that list, when you're starting to reach an extreme of age, we've had a very challenging time when patients start exceeding the age of 65.
Yes. Having
a good survival to, and more importantly, post-transplant. For DT, it's a different conversation. But if your intention is transplantation, age has been a contraindication, a more stringent criteria than we use for other modes of transplant. Aditya, anything that we haven't listed at Sinai?
No, I think those are the main ones that we sort of look in as well. And we recognize that this would be one of the highest risk individuals to be supported with a TAH, given all the risk factors that he carried. However, as you mentioned, it's hard to say and not offer that chance to a young 47-year-old. And we offered, understanding that it's going to be a long tour de force to carry him through it. But if you can, that was the only modality that we felt would be able to support him through this.
What was, someone's asking, was the 50 cc available? And if it was, why not use that here?
Yeah, at the time, we were exploring that, but at the time it was not FDA approved for use in adults at that particular time. So that was not an option for us.
Yeah, it was approved, Dr. Shah, 3 weeks later after that case.
Let me
Wait,
make a comment regarding the 50 and the 70 cc. If you can put a 70 cc, place a 70 cc. We restrict the 50 cc to really small people, that there is no way that we can fit a 70 cc. So the 70 cc is always the first choice if we can put it in.
Dr. Arabia or any of the surgeons that may be on the conference that want to give their opinions on this, there's a couple questions about implanting and explanting the heart, some challenges and how to avoid difficulty with explantation during the implant period. Does anyone have any pointers or pearls? And Francisco, we'll start with you.
Okay. Well, yeah, we have published after struggling for many years on explanting these devices, especially when the device have been longer than 2 months, it can be quite challenging. So we developed techniques to be able to explant the device, and these techniques occur at the time of implantation to make it easier at the time of explantation. And there is a publication about this that goes into detail of all the things that we do. And they include, number one, covering the total artificial heart with Cortex membrane. And actually, we do this now for LVADs, BIVADs, artificial heart. Cover the device with Cortex membrane, plus these blue bands around the aorta, superior inferior vena cava. So it's very easy to get to them without too much dissection. And actually, you can get control of the circulation without even having, in many cases, have to dissect the entire vessels. And the third one is to put a elastic membrane between the sternal wires and the sternum when you close. And that facilitates placing the saw at the time of the reduced sternotomy. And doing these things, and this has been published, we've been able to cut down the reopening and cannulating to bone bypass to just under an hour. When we did not do this, it was taking 2 to 3 hours sometimes to dissect the TAH. And it has been, at least in our hands, so successful that we use it, like I say, for LVADs and BIVADs and whatever that we're going to go back for a transplant. It makes it a lot easier to explant.
I have a question here.
But let me ask you, I would be very interested to listen anyone else who has some other technique, because we're always trying to learn.
Absolutely. Anybody else on the call that would like to share some of their experiences?
Hey guys, it's Rob Dowling. If you can hear me, I just want to echo what Francisco just said about using those blue bands. I learned that from him, and it's been a tremendous help on LVADs or any device.
Thank you. Any other implanters on the line? Okay. And feel free to interrupt or speak up at any time. We have another question about survival, and this is a tough one. There's someone asking, what is the current 2-year event-free survival rates on the TAH? Now, I'll preface any answers to this question with our experience at our center, is that by about the 6-month mark, 85 to 90% of the patients that have been implanted with the TAH have had a terminal event. Either they've been transplanted or they died. And mostly, most patients who are on the device for longer than that period of time are clinically fine outside of the high-risk period, but are not transplanted mainly because of sensitization or pre-sensitization. These are patients that were implanted with a TAH as a salvage for failed allograft. These are patients who were implanted and became sensitized after the device. So there's a small portion that actually, 10 to 15% that end up being long-term survivors. And so it's very difficult to answer a question about 2-year survival when most people, the appropriate length of time to study these devices to have enough power is around 6 months. So I'll let anyone else comment on it that has more aggregated data than my one center, but or any comments on survival at all.
Yeah, Francisco Rabia again. So let me let me, I'm trying to see if I can open the Intermax Survivor for Total Artificial Heart. But I think for Syncardia, it might be helpful to be able to email to all the participants the Intermax registry data for artificial heart, as well as the surgical technique, as there have been questions about this. It also talks about the indications, contraindications, risk factors for death, complication rates. That might be of some value. I'm saying that as I look for this graph. So if someone wants to ask another question while I look for this, I'll try to show it here. See if I can open it and maybe show it somehow. Yes, it might be very difficult.
So Dr. Shah, I think the next question is from, or comment from Dr. Anianwu at Sinai. Maybe would it be, maybe have him kind of weigh in on, Dr. Parikh's commentary, or?
Yeah, that'd be great. Is he still on the phone? That'd be wonderful.
Yeah,
There he is.
yeah, I'm on the phone.
Hi, how are you? Please.
I'm okay. Yeah, so I think it's just the issue of Centrimax. I don't think Centrimax is ever a good solution in a restrictive cardiomyopathy. Because where are you going to cannulate the patient? Because you cannulate the patient in the apex, you still have the same problem. The left ventricle isn't going to fill, your device won't fill, you run into flow problems. Because the data that Dr. Shah showed on the outcomes of LVADs is related to these difficulties in draining a restrictive cardiomyopathy. You could certainly put the cannula in the left atrium and in the right atrium, but then you get obstruction, you get clot in the LV. So I think if you have a restrictive cardiomyopathy, the treatment of choice is a total heart. I don't see any other way. You can try a Centrimax, but the outcomes won't be great.
Yeah, that is right. You will have to cannulate pretty much atria to great vessels. So you're absolutely right. With Centrimax, it's very difficult to do these cases with hypertrophy.
Would you also comment on the specific case presented and some of the challenges and how you handled them as far as the fit and flow accommodating the device?
I mean, the accommodating the device, I think it's just patience and trial and error. You can leave the chest open, as Francisco says, but I generally don't like operating on patients more than once, so I close everybody's chest. I don't want to come back for bleeding. I don't want to come back for anything. So I spent 3 hours, 4 hours stopping bleeding if I have to, and I never come back. And that's the way we do it. So we do try our best to close every chest the first time. And there are different ways to do it, but I think you just have to be patient. It takes time, but you'll almost always get there. So,
you're a better man than me. I get tired in the OR after a while.
Yeah. So we've done about over 30 total hearts, and we've never left the chest open, not once, either for bleeding or for any other reason. And we do a lot of redos, a lot of patients having their second or third heart transplants. We, put a TAH as a bridge. An hour stopping the bleeding. It takes time.
That's remarkable. That's remarkable. We've reached the end here of our time allotted. There's one more question. Maybe we'll squeeze it in. Someone's asking what the typical antiplatelet regimen is at each center for their TAH. Aditya, I'll let you start if you want to comment on this, and if anyone has any.
Yeah, we routinely use a triple therapy with a combination of aspirin, persantin. Our initial for a few years, we used to use aspirin, persantin, and heparin as an anticoagulant. And more recently, we have switched to aspirin, persantin, and bivalirudin. And that's the combination we've been using, and it's been pretty successful with that.
Yeah, we try to keep it simple. We've been starting with a baby aspirin and then follow platelet mapping by TEG. and increasing the aspirin in the first few weeks as necessary. And if we have to go into dipyridamole, we have been staying away from the intoxifiling.
Excellent. Well, I'm going to hand this back over. I think this has been an excellent session and very well attended. And again, thank everybody for the opportunity to let us present on this topic that I think is a unique but frequent occurrence in many of our centers. Thank you.
Thank you, Dr. Shah, Dr. Parikh, Dr. Arabia. To the question on the data, I think Mike Fram works with us at Syncardia, downloaded the Intermax report, Mike, right? And that's on page 2 of that attachment.
On page 3, figure 2, you'll see the competing outcomes that speak to what Dr. Shah spoke regarding the majority of patients have some kind of event prior to the 6-month point. And you can see even at the 12-month mark in this data set, about greater than nearly 66% of the patients either were transplanted or alive on device at the 12-month mark.
Thank you. So, you know, I assume that's retrievable from the Zoom call. So thank you for sharing that. And, you know, we're here to, you know, any questions you might have, and hopefully Dr. Arabia, Dr. Shah, Dr. Parikh would you know, field questions, or a company can field questions on data or other information. Some other great questions that I think we're running out of time for. Just before we wrap, there is this question about switching from ECMO to TAH. Can we just take a minute on that one?
This is a tough one. You know, I'll put a few numbers out there from our experience. If you go from ECMO to TAH, I would do it if you've adequately resuscitated the patient and the patient cannot safely be transplanted. But going from ECMO to TAH as sort of a staged failing therapy ladder climb where this didn't work, we'll try this and we'll try this, and ECMO's not doing so great, limbs don't look good, we'll try this. You're going to increase your mortality on the TAH, and we saw a 3- to 4-fold increase in mortality when you do the bridge to bridge to bridge, and TAH is your third option. So I would be very cautious, but I'm not saying prohibitive. If you have someone that you've resuscitated on ECMO, I think it's, you know, a very reasonable option if the patient can't safely be transplanted.
Yeah, that's a great point. And we look at this information in our hands in Los Angeles, and we publish it. Maybe Syncardia can make it available too. You're absolutely right. The patient who stabilizes on ECMO and improves organ function, that's probably the best patient to be able to take to TAH if you need to give them time. If you have someone deteriorating on ECMO, TAH is not the answer. It's not the solution. If the renal function, liver function is not improving, on ECMO, it's not going to get better with the TAH. And we try to avoid what I call titrating devices. So going from balloon pump to Impella to ECMO to total artificial heart, we try to avoid that. We try to do the definite procedure that has the best chance of helping the patient. We try titrating devices is not the same as titrating anatropes. It has significant morbidity.
Thank you, sir. And I see Mike has published a link to our Annals of Thoracic Surgery paper on implant technique. Correct, Mike? By Dr. Mokadam, yes. So it's an excellent tips and tricks article. So I think our 50cc is approved. We are anticipating DT, long-term approval this summer, working with the FDA right now. So those two indications will be covered, and a lot more to come with data and other new information from Syncardia. This will be the first. I couldn't be happier with how this went. Dr. Shah, Dr. Parikh, Dr. Arabia, thank you Thanks everybody for joining, and look for the next invite on TAH here in the weeks ahead. Have a great weekend. Stay well, everyone. Thank you.
Thank you.
Thank you very much.